All right, good evening, everybody, or good afternoon, wherever you guys are at in the United States. Welcome to the CDI Forum. Today's date is Wednesday, August 31st, 2016. Again, the CDI Forum is brought to you by Compliant Coding Systems. I am your host, Brian Kui, RHIA, CDIP, and it's good to have you all in today's CDI Forum. Our topic for today is antibiotics. Now, it may seem weird to talk about antibiotics because most of the times when I talk about CDI topics, it usually is about what? It's usually about the disease, right? And normally when we talk about diseases, what do? We break it down in such a way that we understand, number one, the symptomology. We understand the treatments. We understand the diagnosing factors. But it's not that, it doesn't always happen that way when you are reviewing a chart. Sometimes in CDI, just in reviewing charts in general, you'll get bits and pieces of a puzzle. And remember, the idea of a three-legged stool is what you need to base your query on. But sometimes you'll only get one piece of the stool, right, to begin with. It never begins and starts where you want to start. It always comes out to where you find something different. For example, like last CDI case discussion, if you guys remember, we talked about the pancreatitis, correct? And the only way that pancreatitis was found was not through symptomology necessarily, but by imaging, right? And because of that, we would have to use the imaging and work our way from imaging to find out if the patient does have pancreatitis or not. So a lot of times in regards to this, sometimes we will look through, sometimes as coders, we tend to overlook things that can give us a clue to what the patient may have as far as a diagnosis. We're constantly looking for things that are documented, but as a CDI specialist, the key is what? To find what is not documented. Does that make sense? So the idea of this presentation is not necessarily to go too much in depth in pharmacology, not too much in depth in infectious disease, not too much in depth in microbiome, because that's not my forte. The idea is to apply some CDI principles when you're reviewing things, and when you're reviewing the chart, you may stumble upon an antibiotic that doesn't make sense with the clinical picture. Does that make sense? So the idea of that is to, when you're combing the chart, when you find something like an antibiotic or even so a certain medication, it should alert you to begin to do some more investigation that will lead to an opportunity to ask the physician for a query. Okay, so that's pretty much it. But before we begin, of course, now I see we have about a good handful of you coming in this evening. I see some new names. I see some familiar names. Okay. Keep in mind that this is not a lecture. I am not here to lecture you. You are here, I am here to guide you. That's all I'm going to do. And the idea is you need to participate. So by participating, Compliant Coding Systems does recommend you utilize a USB microphone headset. This definitely works great because I believe one of the participants was using the microphone headset and we had a great conversation. That's the idea of the CDI forum. It's not a lecture. So when utilizing the headset microphone combination rather than the internal microphone, you're limiting a lot of the internal feedback. So, you know, if you turn on your microphone and you're utilizing your internal microphone, we can hear the typing, the background, and whatever. My setup is very simple, where I have a microphone and headset as well, not just like this, but a really more of a podcasting type of microphone. So that way the audio is very direct, it's less of feedback, and you can only hear my voice. All right, so that ups the quality. So of course, again, you're encouraged to chat. I see all of you have microphones, so please make sure when you want to answer a question, and I'm going to ask a lot of questions for you guys, to you all, Please make sure you unmute your microphone, and when you're done, please mute back your microphone so that way we can eliminate the feedback. Okay, very good. Okay, so I guess before we began, there was a question about the cancellation of something. I don't think there was a cancellation, otherwise I would not be speaking. So the last thing I remember is getting an email for the link to here. So of course, if you're here, there's no cancellation. Before I begin, just know that next Monday, and I'll mention this in the end of the live chat, next Monday is what? Labor Day. So of course, there's going to be no CDI forum because we're all going to relax. We're going to rest our minds and continue back on next Wednesday. Sounds good? So what you see here is our discussion. Now this discussion section gives me an opportunity to find out what you know. So the idea is not to just sit here and wait for other people to talk. Give me an idea of what you know, because what's very unique about the CDI forum is you come here to listen to me, and you're here to interact with me. Okay, and you also collaborate with other professionals that are also here. I'm sure there are professional coders, students, and other professionals as well, along with me. Okay, so we are collaborating with one another to answer each other's questions, to provide feedback and opinions, so that way we can fully understand what this topic is all about. So if you see here on the slide here, we have some questions, and of course they're all related to antibiotics. So basically, let me ask this first question: do we know what an antibiotic is? What is an antibiotic? Okay, I had to scroll down my chat box here, but I see you guys scrolling in here. So I see here the antibiotic's goal is to kill bacteria, okay, such as sepsis. We'll stop right there, sepsis. Okay, medication to treat infection. Okay, medication that fight infection, it kills bacteria. Okay, treats ear infections, strep throats, wound infections. Again, we're hitting the key words here: infections and bacteria. Medicines such as penicillin inhibits the growth or destroy microorganisms. That's a good one, Katrina. Thank you. All right, Basirat. Did I say your name right, Basirat? Group of medication to treat infections. Right. Okay. Thank you, Basirat. Now, I guess the key word is infection, right? But without getting too much into microbiology, there are many types of infections, but specifically, what type of infections do antibiotics treat? And some of you had mentioned them. There's only one thing that it treats. Okay, Pam says bacteria, right. So we got that straight away. So this is specifically for bacterial infections. Okay, this is not viral, this is not parasitic, this is not fungal. If you give a patient an antibiotic on a viral patient, will it do anything? No, because the pharmacokinetics doesn't work that way. It doesn't react to certain organisms which are specifically bacteria. So keep that in mind, is that when patient presents with symptoms and they're treated with antibiotics, that is the key, is that it treats bacteria. So whenever you see a physician order for antibiotics, you should automatically not assume but start to think, is this possibly a bacterial infection? The idea that the fact that the physician ordered something to cover for antibiotics raises the flag for a possible bacterial infection. Okay. Let's see, Tiffany says, no, except cause adverse reaction. Right. Okay, for viral. So that's one thing we'll talk about. We'll definitely talk about the adverse effects in regards to that. Okay. We'll talk about some of the timing in regards to antibiotics. You know, if the patient presented with certain certain infections prior to admission, you know, and then they started on antibiotics. Well, what is that all about? Okay, so we answered the question of what are antibiotics. We talked about what are they primarily used for. Okay, do we know what types of antibiotics are out there? Or another question to frame are, in your experience, what are some names of antibiotics that you know about? Wow, Katrina, you're pretty fast there. Okay. So many: amoxicillin, vancomycin. Okay, Christine, Carolyn, thank you. Penicillin, myacin, Tiffany, Sednafir, Bactrim, right. Penicillin, amycin, right. So there's a whole bunch of them. Okay. The idea of when we talk about antibiotics, I'm not trying to teach you, again, pharmacology. I'm not trying to teach you infectious disease. I'm not trying to teach you microbiology. I'm just trying to give you an idea of what the separations are in terms of the classes and what diseases they treat. Because when you see them, the idea is the name of the antibiotic and the disease it treats. We'll talk a little bit about what they do. Okay, are they bactericidal versus bacteriostatic? We'll talk about that, but that's not our great focus. Okay, so good. Those are some of the names. Okay. Last question. What are the problems associated with antibiotics, especially in today's current state of health, especially with the CDC? What are some of the problems associated with antibiotics? Okay. Caroline mentions hives. Very good, especially if you have an adverse reaction. I myself have a personal allergy to penicillin, and it gives me hives. All right, Lorianne, diarrhea. Okay. Causing things like C. diff. And so that kind of, Tiffany, that will jump into Christine's comment there. Immunity, along with Katrina, misuse and resistance. Okay, and Pam too much given, not effective anymore. So, you know, that's the general idea, is that you have issues like this where patient is, you know, having recurring infections, and what happens? It builds up a resistance. Those bacterial cells get very smart. You're giving a whole range of a whole range of antibiotics, and so it's not doing anything. So what are two organisms, or what is one organism that has come about because of resistance? Do we know? What is one? What is one resistant bacterial infection? Sorry, Katrina. Bacterial infection. Keep in mind we're talking about bacteria. Okay, MRSA. Right? MRSA stands for methicillin-resistant staphylococcal aureus. Okay, so those are the things we want to worry about. Also, there's the abbreviation MDRO. Do you understand what MDRO stands for? No? Okay. MDRO is multi-drug resistant organism. MDRO. So please write that down. MDRO. Multi-drug resistant organism. You'll see that in urine cultures. You'll see that in blood cultures. Those are things that you would be worried about. So The next question is when you see methicillin-resistant Staph aureus or MDRO, what do you think should be done in regards to this, right? How would this situation be handled in your opinion? By the way, it's just your opinion. It's not a right or wrong answer. With the risk of, giving an antibiotic that doesn't work, how should this be handled? Or what should we be looking for in patients who have MRSA or MDRO? Anybody? Okay, sepsis. But in terms of treatment, Ethel, what should we be looking at? Nobody? If you guys don't know, just don't be afraid to say no. All right? Okay, so we have infusions, cultures, no, okay, yeah, clueless. So the idea is it really is the wide variety of antibiotics, right? So when we talk about antibiotics, you'll see the different classes, okay? You'll see that some are stronger than one another. Some of them have different functions. Some of them have different uses. Most antibiotics will cover for the same diseases like urinary tract infection, pneumonia, upper respiratory tract infections, but it's all about what they do and what type of bacteria they cover for. Another thing that I did want to mention is when you're looking at a culture report, for example, like a urine culture, okay, or a sputum culture, or I say urine, sputum, blood culture. They'll do a culture and sensitivity. That's why it's called either a blood or urine culture and sensitivity. So number one, they're culturing for the organism. Okay. Then they take that organism and they do a sensitivity test to see which antibiotic they are sensitive to. So they're already providing a test on different classes of or different types of antibiotics and see which one it reacts best to. And that report itself will provide good data and provide information for the physicians to plan accordingly to select which antibiotic is best. You see? And so who else would be on board as far as a consultant to help aid in that process? What type of consultant would we be looking for as well, aside from your attending physician? There you go. Okay. So we're looking at the big picture, right? So keep in mind that's where you want to look, right? So when you're looking at your infectious diseases, now you're looking for infectious disease notes, infectious disease consults, infectious disease orders, and correspondence with your attending. You're looking at what? In regards to antibiotics, you're looking at medication lists, you're looking at cultures, okay? So it's definitely moved itself away from the traditional looking at the progress note. Am I right? As coders, we're always very focused in looking at progress notes and things that physicians write. But also we need to look at what, the other stuff that physicians deal with. Okay, and that's what we've always talked about this. There's always a coder's mindset, but then there's also a CDI mindset. When you change that type of mindset, it'll broaden your horizons a bit in what you need to look for in your records. Okay? Very good. Okay, so we have a lot of information. On just that one slide, we already covered a lot, right? So we don't have to go too much. So the first thing I do want to talk about is anti-infectives, because the first thing we did talk about was what? That antibiotics treat infections, but I posed that question, okay? Is an infection necessarily bacterial? No, because an infection, you're looking at a broader range. You're looking at a big range of diseases and pathogens that affect the body. So before looking into antibiotics, antibiotics are part of a class called anti-infectives. Okay, these anti-infectives are a class of drugs that cover a wide variety of infections. That includes your bacteria, your viruses, so those are your antivirals. You have your bacteria, which are antibiotics. You have your antiparasitics, okay, such as lice, okay, fungus, antifungal treatments, okay, such as what? C. diff. C. diff is, well, I don't know. C. diff is a bacterial. Candidiasis is a fungal infection. So most of them are treated with certain antifungal infections. Okay, so keep that in mind. And a lot of times when you see viral infections and they're giving antibiotics, that is something that you want to question, because if it comes down to it, you want to monitor, especially with viral diseases, is sometimes they'll say patient probably have condition that is most likely viral, however, is still placed on antibiotics, right? From an outpatient standpoint, I mean, you have to be very definite, right? But an inpatient, you can be, how would you say it? You can provide those possibilities in regards to that. So if there is some type of antibiotics usage, there's some possibility of some coverage of bacterial condition. So to recognize the fact that the use of antibiotics is used for a possible condition, and possible conditions in inpatient coding guidelines can be assigned as codes. Okay? There you go, C. diff, right. C. diff is caused by good bacteria by being right. So it is a bacterial infection. That's why I had to correct myself there, because I remember flagell being utilized for C. diff. So that's why I kind of backed up. It is a bacterial. Okay. So let's look at the uses for antibiotics, right? So antibiotics can be given in many, in multiple ways, through oral, okay, through IV, through central line, okay. Those are usually the main ones. So these antibiotics, as we discussed, specifically are used to treat bacterial infections, bacterial. That's what the idea is. When you see that word, begin to look for bacterial conditions, or look to see if the condition that is being treated for is bacterial or even infectious. Because sometimes there are, when we talk about it later, I'll show you the differences in between the severity level of a patient who has a non-infectious condition versus an infectious condition, specifically a bacterial one. For antibiotics, there are two types. Well, there's many types of antibiotics, but they're usually classified into two ways. Number one, either a bactericidal, which means that it basically kills the bacteria, or there's a bacteriostatic. Bacteriostatics, basically, they prevent the bacteria from producing. Some of them, when we go through some of the major classes, some antibiotics will inhibit protein synthesis. So it'll kind of stop the manufacturing process and the reproduction process of bacteria. So again, this is not really a pharmacology type of course. I'm just giving you a more familiarity and what you need to look for in your chart reviews. So here I listed 10 common classes of antibiotics. Am I going to talk about all of them? No. But I am going to talk about at least 5 of them, which are more common. And when we go through each of the classes, you'll see, okay, I recognize that, and you'll understand it to be this type of class of antibiotic. By understanding that, you'll understand somewhat of the severity. Some things you might ask, why are they giving this antibiotic when they should be giving this antibiotic? Does that make sense? So you can question or kind of wonder why the changes are being made. Sometimes they're treating for a more severe infection. Perhaps there might be an additional infection that may have manifested, but they're not documenting it. These are things you want to start to consider, okay? A lot of times you'll see broad spectrum, okay? Broad spectrum or empiric, E-M-P-I-R-I-C, empiric antibiotic coverage. Those two words are specifically utilized for what type of condition or what type of infection? Anybody? And we've mentioned this before. Broad spectrum or empiric antibiotics? What are we trying to look for here? Or what are we specifically treating for? Systemic what? Systemic infections, which is also known as when the whole body is infected, when the bloodstream is infected, what is it? There you go. You see? So a lot of times, and this is the problem, is that doctors tend to just jump into giving the most strong antibiotic, and that's the reason why we've talked about this, is because of that reason, where they're trying to cover for the worst case scenario for possible conditions. This is probably what has caused the drug resistance H, where you have methicillin resistant Staph aureus and you have multi-drug resistant organisms such as that. Because when patients come in, physicians, they want to cover. So a lot of times when they document, they'll say covering for, and sometimes the condition is not necessarily there, but there's a slight possibility with some clinical indicators such as imaging, such as cultures, such as white blood count. Those are things we want to be considered here. So the 5 common classes, and you see here, I'm not going to go through them all, but we're going to go over penicillins, tetracyclines, cephalasporins, quinolones, macrolides, sulfonamides, and aminoglycosides. I'm very surprised that I could say these all. Okay, so we'll go through them one by one. Not all of them, but at least 5 of them. And of course, if you have any questions, folks, please stop me. I would be glad to address any questions you may have along the way. Okay, so with penicillins, how many of you understand what penicillins are? How many of you have been treated with penicillins? As I told you, I have a bit of an adverse reaction for penicillins. But basically, penicillins, their main function is that they disturb the cell wall synthesis. Okay, so they're more of a bacteriostatic. They protect against or protects against gram-positive bacteria. Okay, so it's up to the infectious disease to make sure that they're covering for that, for gram-positive, and those can be determined by blood cultures, also determined by blood testing. Sometimes infectious disease are very good at looking symptomology and say, well, that's very indicative of a gram-positive type of infection. Okay, so some of the common antibiotics are utilized are amoxicillin, ampicillin, flucloxacillin. Okay, but how many of you are very familiar with amoxicillin and ampicillin? Usually those are given, yeah, right, for kids, right? Specifically for what kind of condition? Okay, upper respiratory infection. What else? Ear infection, sore throats. Right, there you go. You see? So these are the very basic, right? These are to me, these are the very basic type of infections. I'm sorry, in terms of antibiotics. These are like your first level type of antibiotics. Okay. Any questions? Let me know. So let's look at the tetracyclines. These are more of a broad spectrum antibiotic. Okay. Again, these are more bacteriostatics. Again, they inhibit protein synthesis. Some common drugs include doxycycline, tetracycline, and minocycline. Okay. How many of you have ever seen these antibiotics utilized? Okay. Shiri says yes. Shiri, what type of conditions would you say these drugs would be used for? Oh, okay, skin infections, all right. Such as, probably like acne, correct? Cellulitis, okay. Ulcers, okay, very good. Okay, you lost me for a moment, had to go out and come back in. Okay, so did you have any questions, Carolyn? What we're basically doing is we just talked about some of the classes, okay? And of course, if you have any questions along the way, please let me know. All right. The next class is Cephalasporins. Okay. This is a very big group of antibiotics. Okay. There are 5 generations of cephalosporins, meaning that each generation will cover for one another, meaning that if the first generation, like the how would I say it? If the first generation has a resistance, there's a second generation that would cover that, and then a third generation that would cover that, fourth generation, fifth generation. Does that make sense? So these are more coverage of gram-negative infections, and as you see, it includes MRSA. Because of the 5 generations, it's kind of like a new age of antibiotic that has a very slight alteration that allows the bacteria to be sensitive. You see, so it's always constantly changing, and to me, these are some of the stronger antibiotics that I know of. Okay, so you have here, and I'm going to give some of the regular names or the drug names, which is Ceftin, okay, Rocephin, and Omnicef. How many of you have heard of these? What's the difference between gram-negative and gram-positive? Again, this is not, I didn't want to go into the microbiology portion of this. But as far as I know, one is aerobic, one is anaerobic, one grows in the presence of air, one doesn't grow in the presence of air. And that's all pretty much I know at this point. Okay. But how many of you have, so Tiffany says the last one, said Cefdinir, right? Omnicef. Anybody have heard of Rocephin or Ceftin? I know Ceftin is given, especially post-operatively. It's a very strong drug. I know Rocephin is used a lot of cases, especially with definitely MRSA infections. Omnicef is usually given as an alternative for penicillin, especially if you're allergic to amoxicillin. Okay. Anybody else have any questions? Anybody else have any comments in regards to cephalosporins? Is one given for strep throat? Possibly Rocephin, but it usually depends on the severity of the strep throat. It depends. You really can't say if it's given. It depends on the patient and their medication usage. If they have never ever ever been given any type of to me these are more stronger antibiotics. Okay, that's right. So these are more backups, right? See, as I said, Omnicef, Cefdinir is a backup for amoxicillin. So if that doesn't work because of the resistance, or if you're allergic to it, you're usually given Omnicef, at least for kids. Because I remember I have a son who had constant ear infections, and we went from amoxicillin to Omnicef and other antibiotics, so we were rotating like crazy. Okay, any other questions? Okay, so quinolones. So we're getting more into a little bit more stronger antibiotics here. Quinolones are, again, are broad spectrum antibiotics. Okay, their conditions that they treat include difficult urinary tract infections. Okay, Hospital-acquired pneumonias. And you see here, I made a point to add an anthrax and plague. So this is a very strong antibiotic. And some of the common drugs that you'll see are ciprofloxacin. Okay, Cipro you may have seen for what type of condition? What type of infections is usually Cipro given for? Okay, urinary tract infection, good. Okay, Levaquin is used normally for what type of condition? Anybody? Pneumonia. All right, and Avelox. Anybody? Also pneumonia, correct? It's funny because within the past couple of years, I used to see Avelox being used a lot, but now it's been switched for some reason. I'm seeing more Levaquin being given. Has anybody noticed that? I mean, I've been doing CDI for the past 10 years, and within the first, I will see couple of years of me doing CDI, I have noticed that they were using Avelox for a while, and then now I'm seeing Levaquin. So the key thing is, what I'm trying to say here is we understand now the linkage between Levaquin and pneumonias. Sometimes they, even though it says hospital acquired, sometimes they're given for a community-acquired cases. Again, the idea of giving the worst cases type of antibiotic for a least worst case of infection, thus causing the rise of resistance. Okay. Right, Tiffany mentions it's not so nice. It's not a nice med. It's because of the side effects. So please share with me, or please share with the forum. What are some of the side effects? At least with Levaquin. Anybody? What are some of the side effects in relationship to Levaquin? And I'm sure these are some of the medications that you have to eat with food. Am I correct? Okay. So see, muscle and tendon rupture. Wow, I didn't know that. Especially if in the sun too long. Okay. With bad tummy pains, bad stomach aches. All right. Okay. But I definitely seen Cipro. I've definitely seen Avelox. I'm sorry, Levaquin, but not so much Avelox anymore. Okay. Also headaches. Any other ones? Okay, so let's move over to macrolides. Macrolides are specifically bacteriostatics. All right, they're common conditions that are being treated for are community-acquired pneumonia. Okay, also skin infections. Skin infections, as we've already talked about, such as cellulitis. Okay, infected skin ulcers, wound infections. Okay, especially if there's pressure ulcers and it's infected. Some of the antibiotics that you'll see here is azithromycin, clarithromycin, okay, erythromycin. So how many of you have seen these type of drugs being utilized? The one that I definitely know is the Zithromax. There you go, the Z-Pack. So the Z-Pack is probably used, especially for what? Pneumonia, okay. Katrina says STDs. Right? Most definitely. Thank you very much. Now, with STDs, what else do we have to worry about? And Tiffany mentions bronchitis. Thank you. When you mention about STDs, what else do we have to worry about? Doses start treating another person, right? At least with STDs, we also have to worry about AIDS, HIV, AIDS. Even though it's a viral condition, right? But the opportunistic infections can be bacterial, right? So let's take a look at this. I believe this is the next one. Hopefully that's right. There you go. So let's look at sulfonamides. You like that transition, right? So the sulfonamides, the coverage includes some gram-positive bacteria and also include many gram-negative bacteria. So the conditions for sulfonamides that they treat is UTI and also pneumocystis pneumonia. Again, pneumocystis pneumonia is associated with AIDS. Okay. So some of the most common drugs that you'll see here is Bactrim, azulfidinine, okay, and sulfasoxolone. Okay, but I definitely see Bactrim being utilized a lot. So when you have a patient with AIDS and they're covered with pneumonia and they're given Bactrim, all right, that definitely can raise a question to see if this is a bacterial infection that is AIDS related. And so usually you might have to ask, or look for, other things that may be related to PCP, pneumonia. Because remember, when you're looking for something with AIDS-related conditions, you're not necessarily looking for an opportunity, but you're looking more from a safety perspective that we want to make sure that the bacteria organism is stated in a patient with AIDS so that way it is properly reported. Okay. Any other questions with sulfonamides? All right, the next one is aminoglycosides. Again, this is a bactericidal antibiotic. Okay, the coverage is for aerobic gram-negative bacilli, staphylococci. Okay, also you see here Mycobacterium tuberculosis. So this one definitely, you might have to be worried about this because especially in a patient with tuberculosis, what are some of the safety precautions related to tuberculosis? Anybody? What do we have to be worried about in a patient with TB? Or how should we treat this patient who has a possibility of having TB? Where do they need to go? Okay, Christine mentions airborne. Basirat says contagious. Right, so there needs to be some type of airborne precaution, some type of isolation. Okay, so when you see some of these things like gentamicin, tobramycin, amikacin, and they possibly might have a history of TB, you might want to be concerned. Okay. Even though there are a lot of tests in regards to that, if they start to begin to treat for patients like that, then you might want to start seeing if it's a possibility. But even with TB, again, tuberculosis, you don't want to be coding any possible conditions. These are the things you want to make sure that they are for sure and definite. Okay, so are there any other questions in regards to the different classes? I mean, the idea is just to get you familiarized with them. This is, again, just a very basic level antibiotic type of lecture. I mean, of course, we can go more in depth, but I don't see where, we want to do that within the range of time that we have in this session. Okay, so let's look specifically at the CDI opportunities. Okay, in regards to antibiotics. A lot of times the first one here is looking at infectious versus non-infectious. Okay. One condition that I can definitely tell you that I usually see this is gastroenteritis. A lot of times patients come in with abdominal pain. Okay, they came from a restaurant and they were very sick. Okay, and a lot of times doctors will just state acute gastroenteritis. But in the next slide, when I'll show you later, there is specific codes that are that differentiate from a non-infectious to an infectious type of gastroenteritis, specifically from gastroenteritis to bacterial gastroenteritis. You see? So that's one thing that can be a query opportunity, and it'll definitely change a lot of things in terms of the classification of payment and reimbursement for the case. The next one is bacterial versus non-bacterial infections. Okay, one that we have talked about in the past has been pneumonia. So pneumonia, of course, you need to find out the type of pneumonia. And with pneumonia, we're looking at aspiration, but specifically we're looking at bacterial pneumonia. And usually we would find this if the patient is on Levaquin or some type of antibiotic like Rocephin, or if they're given broad spectrum antibiotics and the patient definitely has pneumonia. Well, you know, is the patient then being treated for a bacterial infection because the patient is on an antibiotic? Because usually that is the treatment, you see. So the differentiation is between infectious versus non-infectious, but when you think about non-infectious, there's always a considered for inflammation. Sometimes it's caused by something else that doesn't cause an infection, but more like an irritant. You see, so rather than pneumonia, it could be pneumonitis caused by some type of chemical, or perhaps it's really true pneumonia that is caused by an infection. And usually we try to look for it to see if it is a type of infectious etiology. A lot of times with patients with pneumonias, when they come from like a nursing home, okay, you can definitely see that they're harboring something, okay, and they're given an antibiotic. And sometimes we can get a sputum, but sometimes sputums are not too good of a reading because, you know, keep in mind that sputum, in order to get a true sputum reading, they have to come within deep in the lung. Sometimes you get it right in the throat and you may not get anything. You'll get the normal flora. So those are the things we want to consider. If the patient's on a specific type of antibiotic, perhaps you can ask, depending on the situation, if it is documented one way as possible bacterial, and then I've had the intending just say pneumonia, okay? If there's a collaboration in that, you can utilize the antibiotic to say, well, look, you know, you're giving a specific antibiotic. There is some type of mention of bacteria in there. Sputum is positive for this, and you can actually utilize for that. Okay. Tiffany says, hiccup here is doc doesn't test to see if it's bacteria. They assume always that it is bacteria. Right. They assume, right? They assume it. But again, the challenge is, are they going to write it? You'll talk to a doctor and it says, of course, you know, if I'm giving antibiotics, it's because it's for bacteria. But the key is that they need to document that. You know, what's nice about inpatient documentation is that they can say it is, did I just move to the next slide? Sorry. It is bacterial. Okay, but we need to reflect that. And when you're posing your query, you can actually utilize the bacteria as one of the, the antibiotics as one of the sources. Okay. So the next question here that we want to look at is, what is the antibiotic being used for? So sometimes you will not get the documentation mentioned here. Okay. Sometimes they won't say it. Sometimes, again, they may say infiltrate, or they, you know, patient has elevated white blood cell leukocytosis and they're giving a patient antibiotics. And there's a missing diagnosis, but however, you got all of the clinical pictures that are mentioned, and the last piece is that they're giving the patient antibiotics. Okay. Infiltrate. Infiltrate is a finding on the chest x-ray, and usually chest x-rays, infiltrates are indicative of pneumonia. So when you review charts and you see infiltrate, it's usually very synonymous to a pneumonia or some type of upper respiratory infection. Okay. Tiffany says, why don't the test first? Why? I'm sorry, I didn't really catch that. Why don't they test first? The sputum, is that what you're asking for? What if the patient can't produce any sputum? Then you're stuck. Sometimes they don't produce that. But a nasal swab is not really, because remember, in order to get a true pneumonia, where's the pneumonia, Tiffany? It's in the lungs. Okay? If you do a nasal swab, it's not really a true indication of finding. I mean, they really have to cough way deep or really sneeze. Remember, the nasal swab is upper, okay? Pneumonia is deep in the lung. It could be, but if the doctor's already writing pneumonia, I think that's our point. And usually I don't really see for pneumonia patients they would do a nasal swab, unless again it's to treat for viral conditions. But again, we're not talking about viral conditions here. Okay. I get what you're saying though. Infiltrate and infection, not all the time. Della, going back to Della's question. Infiltrate is not always an infection. Now, if you combine an infiltrate with an elevated white blood count, like leukocytosis, okay, on top of a fever, on top of shortness of breath, and they give the patient antibiotics, well, come on, what is it that they're treating? They're not treating an infectious infiltrate. I mean, that's not something you put on a, you can code. Unfortunately, that goes to an abnormal chest x-ray finding, and that's not acceptable, right? We want to be more definite about that. Okay, so what else do we have here? What is the antibiotic being used for? Antibiotic being ordered, but condition is not documented. So that's the one thing that we talked about. Combine antibiotic with test finding to provide specificity in your query. So that's a very good example that you just brought out. Thank you, Della. So, you have findings, you have symptomology, and you have treatment, but the documentation is not there. And it is usually when the physician gives that treatment, it's usually that type of, that's the evidence you want to go ahead and move forward with the query. And it's usually an antibiotic, and those are the things we want to look for. But however, if you're not familiarized with what the antibiotics are, thus this being the reason for the forum, then you are actually missing out, you see. So this is why it's very important to also know, be familiar, not necessarily know in depth, just be familiar of what an antibiotic is, so that way you can move forward with your query. So let me give you some examples of ICD-10 codes here. All right, just very basically you have pneumonia, J189, and then you have J158. All right, so that goes from pneumonia to bacterial pneumonia. You also have gastroenteritis. All right, so you have from non-infectious. It could be, just because the stomach is hurting. It could be more like a plumbing issue rather than an infection. And then you have bacterial gastroenteritis. So like if they ate really bad food, okay, or if they're sick and it spreads to their stomach, those are things we want to consider as well. Sometimes non-infectious gastroenteritis may be related to antibiotics. Would you guys agree with that? So you guys have to be very careful if the patient is being placed on antibiotics and the reason for coming in is because of the adverse effect, which we'll talk about in a second. Okay, and another example is endocarditis versus bacterial endocarditis. And I think we had mentioned this, especially with the cardiac enzymes. You can have positive cardiac enzymes which resemble the heart attack, but if you throw in the fact that the patient has leukocytosis, white blood cell count, and the patient is being treated for certain, with a certain antibiotic, that can move you to ask if the endocarditis is infectious or not related to bacteria. All right. In the next slide, what I want to show you is the MS-DRG differences. Okay. Again, there's not much change into the coding, but look to the far right. Okay. Don't worry about the MS-DRGs. Again, it's just a simple classification. It's nothing for us to really delve too much into, but I want to show you is the difference between pneumonia and bacterial pneumonia. Take a look at that. The relative weight is much higher. When I say relative weight, this is a consumption of resources that is allocated for the condition. So just in case you have a question on that. The higher the relative weight, the more resources that it should be given for that condition. Does that make sense? So the lower the relative weight, the less resources that are being utilized or should be utilized. So look at pneumonia. Pneumonia and bacterial pneumonia from 0.711 to 0.9659. That's a good small jump. Okay. Let's also look at non-infectious gastroenteritis to bacterial gastroenteritis. A good example could be salmonella. All right. Look at the jump there, 0.74 to 0.78. Again, it's not too big, okay, but it is, but also consider the MS-DRG classification changes. So that will create a varied type of case mix, and with that case mix that actually goes up, okay, and that affects the hospital reporting, that affects the hospital reimbursement rate, you know, and quality as well. The last one I want to show you is endocarditis. Look at the change. It's very big, from 0.844 to go to a bacterial endocarditis to 1.0546. Okay, so these are the things that are very important with MS-DRG. Another thing in regards to opportunities, especially with antibiotics, especially with medications, is underdosing. Okay, you want to monitor to see if the patient is taking the medication. Perhaps the patient had the infection in the first place, but you also want to monitor the usage. The patient was non-compliant with medication and thus returns back with the same infection. You see? So in terms of quality, they're very worried about readmission rates. However, if you capture the underdosing of a specific drug and the intent, okay, that will paint a better picture for Medicare or third-party payers to say, hey, look, it's not because of the institution, it's because of the care of the patient that they didn't want to take the medication, either because it was intentional. If it was non-intentional, they were in a financial crisis, or they just didn't want to take it at all, or they were very forgetful. You know, those are things that we want to capture. Okay. We also mentioned the adverse effects. Sometimes patients are given antibiotics but then receive adverse effects. But then we have to question is what brought them in? Well, you know, the patient may have been in another facility, taken the antibiotics, got an adverse reaction, thus gets admitted. So the question jumps into the chronicity of the condition, you see. You know, is it present on admission or not? What's the acuity of that condition, especially if they're still taking antibiotics? Those are things that we want to consider, okay? Other things you might want to look at is when was the antibiotic started? When was the infection diagnosed? Those are things that can come into play, especially that it will affect the present on admission and also the chronicity of the condition, okay? All right, I'm done. So is there any questions in regards to antibiotics that we just talked about? Is there any questions in regards to the CDI process related to antibiotics? Is there anything in relation, any questions in regards to CDI? What were the last two antibiotics on the chart you showed previously? From the CDI case discussions? Or from this presentation? Della, I'm sorry. The last two antibiotics, let me go back. Are those it? Gentamicin, tobramycin, amikacin, Bacmor, Bactrim, asulfonide, sulfasoxanol, sulfasoxazole. Is that the one? Della? Oh, there was a list of 10 most common classes. There you go. Okay. Okay, take a look at that. This was informative. Thanks for explaining. All right, cool. Thank you very much, Deborah. All right. Okay, so as Della is writing this down, I'm going to thank you guys for coming out this evening. Again, I do want to thank you guys for coming out. Keep in mind and let me know, Della, when you're done with this. Keep in mind on Monday, there will be no CDI Forum. Thank you. Okay. Only because it's Labor Day, so please make sure that you guys enjoy your Labor Day. Everybody stay safe, especially with those hurricanes. I know in Florida, they're going to come up and around. And everybody up from Atlanta, North Carolina, South Carolina, everybody stay safe. Our next topic will be CDI case discussions. That'll be on next Wednesday. So again, I'll bring 2 cases for you to review. Okay, and again, thank you for being with us. The CDI Forum is brought to you by the Compliant Coding Systems. Okay, again, presented on Mondays and Wednesdays at 8 p.m. Central Standard Time. Let's see, Pradnya, before we end, can we get a copy of the slides you used today or other prior CDI Forum discussions? With questions in regards to that, please make sure you contact support at compliantcodingsystems.com, Pradnya. Okay, they would be, I uploaded for them, so that way they have access to that. Okay, so I'm sure you can get the slides for sure. Again, for any information or upcoming existing and Coding Academy courses, please make sure you visit www.compliantcodingsystems.com or the updated www.compliantcodingacademy.com. Again, my name is Brian Kui, RHIA, CDIP. Thank you for coming out this evening, and we'll see you all next week. Have a good night.